Next, I'm going to introduce Dr. Amber Shada. Dr. Amber Shada is from Wisconsin. She did her undergraduate work there, or medical school, I'm sorry, there, and then went off to University of Virginia to do her residency. And then after that, moved to Portland for a year and trained under Dr. L Swanstrom. Amber is a rising star right now in the world of foregut. She's back at University of Wisconsin where she's assistant professor. And clearly her training has led her to be one of those people that we're already talking about, and she's only just a couple years into her career. So Dr. Shada, if you could come up and introduce Dr. L Swanstrom.
Thank you, Mike. That was incredibly humbling, as is the opportunity to get to introduce and interview Dr. Swanstrom. So many of you know these things. Dr. Swanstrom is one of the division heads of GI and MIS surgery at the Oregon Clinic in Portland. He also holds a clinical professorship at OHSU in surgery. He's a member of the American Board of Surgery, a past president of SAGES, Fellowship Council past president. He started his undergrad training at the University of Colorado and the University of Paris. And then went to Creighton for his MD, went to OHSU for residency, which is where the folklore and stories started, I suppose. And did a year of extra training at Western Ontario, the University of Western Ontario, in surgical endoscopy and GI surgery. He is a true pioneer. The list of things that he has been either the first or among the first people to do is gigantic. For example, among the first to do a laparoscopic Nissen fundoplication, among the first to do a laparoscopic Heller, first transgastric cholecystectomy, and first endoscopic pyloroplasty. He has, his list of publications grows every time I look at it. And as a trainee of his, when you ask a question, if he'd published on it, wouldn't answer your question. Say, you know, I've written about that. And then you'd have to dig through PubMed, the 300 publications, and try to find the answer. He's also written many book chapters. He's the editor of 2 major textbooks, Surgical Innovation Journal. He's a researcher in new procedure development, not surprisingly. He has several patents. He has his own medical startup. He's been an investigator on many outcome research studies for notes. Safety and efficacy is the most recent. He is a consultant to several of the device companies, and he does important work moving technology forward in a meaningful way for surgeons. So, and among all these amazing, incredible accomplishments, if you ask him, the thing he's most proud of is his trainees, the fact that he's inspiring people and continues to inspire us to push the envelope in GI surgery. As I alluded to before, Lee is probably best known for his quirks. A lot of these have elevated to a folklore level. So he's known for rounding on his patients in roller skates, plus or minus a wig. He burns incense and meditates in clinic. Definitely meditates in the OR, especially when some of his fellows are operating. And of course, no one will forget the eye patch. He splits his clinical and personal time between the United States. He's been in Portland the vast majority of his career, but now spends time in France at the University of Strasbourg. He has an orchard in the south of France, in Alpes-Maritimes, and enjoys restoring paintings, and he does book binding of ancient manuscripts. So I find all of this stuff fascinating. And I'm really excited to hear what he has to say about the history of anti-reflux surgery. Okay, so.
That was very nice. It's very nice to be here, surrounded by fellows and mentors and two of my best friends. So.
Yep. So take us back to the early days of laparoscopic fundoplication. Some of the exciting things, some of the hurdles.
You have to go back to 1990 when we first started thinking about it. Me and John Hunter, stimulated by Alfred Cuschieri, who was kind of a mentor and a friend of ours, and who was one of the early pioneers as well of this. We were at that time, after lap chole, a couple years into lap chole, looking what we could do with this amazing technology of laparoscopy to really spread that. We thought that that was the future of surgery and that. I have to say, back even before that, I was instilled with a love of the esophagus by Tom DeMeester. I was at Creighton during my training as in the advanced surgery medical student thing, so I was kind of his personal retractor for many cases. But I was inspired by his love of the esophagus and kind of took that with me into residency and training and carried through that. So I had an interest in research basis in esophageal and gastric surgery. In fact, when I first started in practice, I inherited a practice in Portland that was one of the biggest in the state in anti-reflux surgery. And we actually did, at that time open, of course, did a grand total of about 8 a year, which is by far the highest volume. So it was kind of a dying procedure at that time. So the technical hurdles as we kind of worked through this in animals and tried to solve the problems of doing it were that we lacked good video feeds. Imagery at that time was primitive. There's no things like harmonic scissors, scalpels, anything like that, staplers. So everything was hand-tied or hand-clipped. Clips was the most complex instrument we had at that time. And so it was a painstaking and frightening thing to kind of go through that. But we did kind of worked it through and kind of crossed those hurdles, clipping each of the short gastric vessels and dividing them, tying them off, and eventually felt good enough to do the first human.
And what do you think is maybe the most overlooked part of the fundoplication for the average surgeon?
Well, I think as Tom DeMeester said, I think it's not a surgery that's rote. I mean, it's everybody's stomach and gastroesophageal junction and hiatus is unique and different. And I think because of that, every time you do a fundoplication, it's a different procedure. And that's very hard to teach and it's very hard to do. You have to focus, you have to understand the anatomy, the complex interplay of the different structures to do it. I think that's the single most difficult thing about fundoplications is understanding that and addressing it. I think the other thing that I've kind of learned along those lines is that it's not just the GE junction. You really have to take into consideration the whole upper digestive tract. And one of the early things I discovered is that if a person has a bad stomach or a bad esophagus, you need to address that or you're going to have mediocre results.
And you put, let's say the average surgeon who does a Nissen will put about 3 stitches in their wrap. And you put 8 or maybe 9. Mm-hmm. Can you explain your thinking behind that?
Yeah, you know, I started, certainly when I did open fundoplications, it was 3 stitches, a couple stitches in the hiatus and three anterior sutures. You know, I think in laparoscopy, the good thing about it is it's less tissue destructive and therefore less pain for the patient. The bad thing is that you don't have a lot of talky handprints on it to hold it in place afterwards. So slowly, as you know, I never like doing the same thing twice. I'm always questioning things. So, and I'm a little bit additive as well. So I gradually over time said, well, this is the third redo that we did where the right side of the wrap herniated up into the mediastinum. By God, I don't want to do that again, so I'm going to try a stitch here and see if that helps. I think one of the most important things I did early on was carefully capture all the data on every patient we did and follow them up religiously. All the fellows are painfully aware of calling patients and trying to get them to come in for their 1-year PH study for their upper endoscopy. But that's over time, the sutures accumulated more and more of them until kind of got to where there are around 9 of them now.
Yeah, I heard. Went from 8 to 9. Can't wait for 10. We do pretty well with anti-reflux surgery. I mean, if you measure by patient satisfaction, I think it's approaching excellent, but we can probably do better. And I think the rate of recurrence of GERD symptoms and people being back on their meds can be high, depending on the study you look at. So what can we do to make that better? What improvements are we not capturing yet?
Yeah, that's a good question. I think meticulousness of technique, understanding the disease through thorough studying of the patients has driven the recurrence rate down, maybe as low, but it's in some ways it's like achalasia. It's not really a curable disease, and we're putting a bulwark up against it. We're using natural tissue by and large, and that has a senescence. When we've looked at patients now out past 20 years, there's a steady decline, even of the ones that were tremendously successful, of about 1% per year will just become senescent and fail. I'm not sure that means that it's a bad procedure. It's just the way human tissue loses its elasticity. And luckily, it's not insurmountable to go in and do a redo case to kind of salvage those cases.
Mm-hmm. What do you think, if you could give your younger self some advice, what do you think you would tell him?
Well, I think, one of the seminal things about laparoscopic Nissen, was it revitalized surgeons' need and interest in flexible endoscopy. Lap chole and everything was not that critical, but it really introduced that. And if I could go back in time and talk to my younger self, I'd say, set up a better database from the beginning. Spend as much money as you can dig up to get the best outcomes database that you can, and be aggressive at getting into flexible endoscopy and diagnostics. So master manometry, master physiology studies, and become as quickly as you can a master endoscopist, because I think those are the things that really have helped me in the end have a really successful practice in anti-reflux surgery.
And what do you think is next on the horizon for anti-reflux surgery?
I still have, I'm frustrated when I do Nissens because, patients are satisfied, 90% satisfied with doing it. They have problems afterwards. They have flatulence and bloating and early satiety, and almost all of them have that, and that frustrates me. I really want them to be perfect. So I still think there's promise in endoluminal. Someday, maybe endoluminal or some injectable cellular therapy that's going to kind of correct more physiologically the fundamental problems and defects. I think LINX is an advance along those lines. I think some of the endoluminal treatments are coming of age, and hopefully will help with that.
Yeah. That's all the questions I have. I don't know if anyone else has any questions from the audience.
Save them to the end.
Okay.
Yeah, we'll do,
Great.
Yep. Thank you very much.